Hi, this is Brian Kim. I'm going to share with you case number 44 in the best way to do cataract surgery series. This is a dense cataract with a pretty nice sized pupil, so you'll be able to see systematic disassembly of the lens using double chop, cross chop, mechanical fracturing techniques. And you can see as a result of these techniques, I can have a reduced CDE, and as a result, postoperatively, nice clear corneas and really a safer approach to surgery. So I'm using a cotton tip to help center the eye. I'm going to use a corneal marker to help me center and size my rhexis when it's time for rhexis. Use a cotton tip to turn the eye. I'm going to make my paracentesis incision first inferiorly here. And I'm making the incision flat to the iris plane. Do the same thing on the left side. Have the patient look down a little bit, and with some support using the cotton tip, have a flat approach. You want to have a nice corneal shelf, which will allow me to have a self-sealing corneal incision. I'm injecting some intracameral lidocaine and then intracameral dispersive viscoelastic to fill the anterior chamber. And then I'm going to begin the triplanar corneal incision. I'm going to use my diamond blade to make a vertical groove, and then place the tip of the blade into the deep part of the groove, tunnel through the cornea, and then use the cannula, which is holding the eye, turn the eye toward me, and then enter. This is the triplanar corneal incision. The cannula helps manipulate the eye for the incision. Going in with the capsule rhexis forceps, doing my puncture style technique, puncturing centrally, pulling downward, and then grasping the right side to create a flap. I'm using the corneal mark, which is going to help me center and size the rhexis. I'm following the mark, going around circumferentially, grabbing and re-grabbing every couple of clock hours. You want to keep the teeth in a horizontal configuration, which will allow you to grab the capsule flap nicely, as well as minimize any viscoelastic egress. I'll go ahead and finish off the rhexis here. I'm going to burp some viscoelastic out of the eye. And then I'm going to begin the capsular fornix hydrodissection technique. Place the cannula out to the contralateral equator, point the tip downward. You get a nice fluid wave. Decompress on the left side, and then place the cannula under the rhexis, point it down, and then I'm able to spin the lens quite nicely. I'm going to irrigate the cornea with some fluid, and then I'm lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material, and this begins the double chop maneuver. Place the chopper out to the contralateral equator. Place the phaco tip vertically, subincisionally, crushing the lens between the chopper and the phaco tip, bisecting the lens into two pieces. Place the chopper out to the contralateral equator, and then crushing the right heminucleus, pulling the chopper towards the phaco tip. So I pull that first quadrant up with a little bit of vacuum, go around with the chopper, crush and bisect that first quadrant in half, using mechanical fracturing forces to crush the lens pieces. There was something wrong with the phaco tip. It was not really removing the lens pieces normally, and so we flushed the handpiece and tested it, and now it's working more properly. So I'm going to get underneath the capsule rhexis edge here, pull it centrally to bisect that second quadrant, and then I'm using some high vacuum as well as ultrasonic energy to emulsify that second quadrant. So you can see most of that CDE was used because I was testing the handpiece outside of the eye, and so you have to take that with a grain of salt. Rotating the second heminucleus in front of me, place the chopper out to the equator, pulling it centrally toward the phaco tip, crushing and bisecting the second heminucleus, and then do the same maneuver, and then bisecting the third quadrant, and then crushing it with mechanical fracturing forces and emulsifying the lens pieces. You can see this is very controlled, systematic lens disassembly technique. This is the final quadrant. Place the chopper out to the equator, pulling it centrally towards the phaco tip, which is placed deep into the lens material, crushing the lens in half, and then emulsifying the lens pieces. This is the last portion of that fourth quadrant, pulling it centrally toward the phaco tip, and then emulsifying the lens pieces. So again, you want to use double chop, cross chop, mechanical fracturing. You can see the disassembly of this lens occurred quite easily, using the chopper tip to hook the lens pieces toward the central safe zone. This is very controlled, very safe maneuvers. Removing the epinuclear material using the same setting, take the chopper out, push BSS in, take the phaco tip out, and then switching to the INA handpiece. This helps minimize significant pressure differential in the eye. I'm starting the cortical removal, starting subincisionally and going around circumferentially. It's such a powerful machine, and the vacuum and aspiration is so well controlled. It's really very routine in my hands. I'm removing the cortical material from underneath the anterior capsular rhexis edge, as well as now removing cortical material from the posterior capsule surface. I'm just polishing using this polymer tip, which is very safe. Polishing the posterior capsule surface as well as the anterior capsule surface. I'm pushing BSS through the paracentesis into the subincisional capsular fornix just to see if there's any remaining cortical material left. You can see it was pretty clean. Now I'm injecting some cohesive viscoelastic into the capsular bag, and then I'm going to begin this sweep where I'm going to sweep underneath the anterior capsule edge. This is to remove any lens epithelial cells or any hidden cortical material. Sweeping first on the left side, and then now on the right side. And then I'm injecting the single piece acrylic intraocular lens into the capsular bag, placing the leading edge into the bag, and then using the INA to inflate the eye and then position the haptics as well as the remainder of the optic, disengaging the haptics from the optic, going underneath the optic, rotating the lens 90 degrees, tilting it, making sure all the viscoelastic is removed from within the bag. I'm polishing underneath the anterior capsule edge because there's always some fine lens material that's remaining under there. And then rotating the haptics in a more horizontal orientation here. Polish a little bit more, and then we're ready to go. Remove all the viscoelastic from the anterior chamber. Whenever there's a lot of viscoelastic still left in the chamber and coating the cornea, that's really a telltale sign that your technique is a really good technique. If you don't have a lot of viscoelastic in the eye, that means you spent a lot of time irrigating, aspirating, using vacuum during your lens disassembly technique. But if you have a lot of viscoelastic left at the end of the case, that usually tells you that you really used minimal fluidics to disassemble and remove the cataract and putting the lens in place. Once the lens is centered, I take the INA handpiece out, push BSS, and hydrate the incisions. So this is a moderately dense lens. I use double chop, cross chop, mechanical fracturing techniques. This is an easy and systematic approach to cataract surgery. As long as you master being able to place the chopper out to the equator and pull it towards the center, crushing the lens pieces, you can hook lens pieces, pulling them out of the bag. To me, this is really the most efficient and most controlled and safest way to do cataract surgery. And in particular, with these dense lenses, you'll have reduced CDE as well as much clearer corneas postoperatively. So I hope this was helpful to you, and I thank you for your attention.